Hello, you're listening to Health Professional Radio. I'm your host, Neil Howard. Thank you for joining us. We're going to have a conversation with Dr. Pamela Jones. She's from Massachusetts General Hospital, and she was a presenter at the 2019 American Association of Neurological Surgeons scientific meeting, and she's joining us here to talk about the latest updates on performing minimally invasive endoscopic neurosurgery for treating tumors in the skull base and pituitary. Welcome to the program, Dr. Jones. Thanks for taking the time.
Oh, thank you. Thanks for having me.
Now, I did mention, of course, that you're from Mass General, the presenter at the 2019 AANS. Give us a bit of background about yourself, and let's talk about this meeting.
Well, I'm a neurosurgeon at Mass General Hospital, as you mentioned. I specialize in brain tumors and pituitary disorders and tumors of the skull base. And, I'm involved in research and education and teaching of med students and residents as well. And yes, I attended the meeting. I was in San Diego just a couple of weeks ago. And
are these tumors? Are they cancers? They're always cancer, or are there other types of growths or problems that may not be cancer related that you deal with?
So I deal with a few types of tumors, and some of them are cancerous, and some of them are non-cancerous. Generally, the tumors that I work with that are pituitary tumors are non-cancerous. Those are by and large benign lesions, unless they represent metastases from somewhere else, which is a rare case. But otherwise, they are benign lesions. But the problem is the location of where they grow and the problems that they can cause by growth in that region.
Well, let's briefly talk about the importance of that area, the pituitary, the base of the skull.
Yeah, the pituitary gland sits in a bony area called the sella, and right above it are the optic nerves traveling back from our eyes into our head and transmitting the information of our sight. So obviously of critical importance. So when tumors grow within the pituitary gland, oftentimes they can grow upwards and therefore put pressure on the optic nerves and cause vision change or even vision loss. So that's one big reason that we go in and resect these. Another is that there are other nerves that control eye movement on either side of the pituitary gland, traveling in a region called the cavernous sinus. So we also might treat tumors in this region to help with relief of pressure on those nerves, which can cause double vision or trouble raising your eyelids, focusing, things like that. That might involve a multidisciplinary approach with some surgery and radiation.
Is it actually brain surgery, or is that too of an all-encompassing term for what it is that you're actually doing in the base of the skull and the pituitary?
Yeah, the pituitary gland communicates with the space. So it is, it's beyond the coverings of the brain. It's not actually, there are no nerve endings within the most of the pituitary gland. So it's a little bit of a separate entity, but it is part of what neurosurgeons do. So it is included within brain surgery. But mostly it's a gland associated with the brain, just like the thyroid is a gland, or our adrenal glands are glands.
Now, traditionally, when you were working in this area of the skull and on this gland area, are you opening up large areas of the neck, lots of recovery time? Are there small incisions, large incisions? What was the norm?
The vast majority of these tumors are removed by going through the nose. There are no scars on the face.
Okay.
People don't look any different when we were done. So we go through the nose and enter into the sphenoid sinus, where the sella sits, and remove some bone from the sella and enter into the area where the pituitary gland sits that way. So people tolerate this very well, as you can imagine, with no real incisions and other than some mucosal incisions in the nose. So people tend to go home the following day after these surgeries. They have headaches and sinus congestion for a couple weeks, depending on the patient. And but this is one of the brain surgeries that we do with one of the lowest morbidities and mortalities of any that we do. So it's well tolerated. When there are extremely large tumors that are extending far beyond up beyond the sella, compressing the optic nerves, compressing brain matter, and we do a craniotomy and an incision hidden behind the hairline and require a bit more bony removal. But the vast majority of these tumors are removed through the nose.
Now, at this meeting that you were a presenter at the 2019 American Association of Neurological Surgeons scientific meeting, what was it that you were presenting, and is this procedure is it more or less invasive than it was before?
So this is one of our annual meetings, and I was lucky enough to be asked to be a faculty presenter there, and I did speak in a session on pituitary tumors. No, we've been doing transsphenoidals, so surgeries through the nose since the early 1900s. So it's not something new. The advent of the microscope in the 1960s allowed us to do these with more safety and expanded the role certainly. And then in the 1990s, the endoscope certainly helped bringing light actually to the source or to the area of the sella itself. This is not, I would say, not a new technique within the past couple of years, but just one that is continually developed and involved with our ear, nose, and throat colleagues and neurosurgery doing these surgeries together.
Now, is there some place online that listeners can go, or some place where we can get more information about the meeting and about this type of surgery in general? There
is the AANS website, certainly that has the meeting program. And as for information about transsphenoidal surgeries, I'm sure there's a vast amount of information online. The site certainly has a lot about our center here and our neuroendocrine center and pituitary center.
Well, thanks for joining us here on Health Professional Radio this morning.
Thank you so much.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Transcripts and audio of this program are available at hpr.fm and healthprofessionalradio.com.au.
Thank you for listening to Health Professional Radio. We're very proud to be an independent broadcaster providing our content free of charge to you, the listener. One of the ways that we're able to remain free and independent is by having people like you become patrons. You can support Health Professional Radio simply by visiting hpr.fm and clicking the button that says Become a Patron. Your patronage of even just $1 a month lets us know that you're there, which in turn makes us more valuable to advertisers. And, of course, if you're able to afford more, then we would certainly appreciate the support. My name is Toby Longhurst from Health Professional Radio. Please visit hpr.fm, click the Become a Patron button, and support us if you can.